Okay, thank you very much. Thank you very much, dear members of the WFNS Neuroanatomy Committee, dear Imad, dear Vladimir, dear Dr. Ratner. Thank you for the invitation. It's a great pleasure to be part of this panel of experts. All of them, I know them since more than 30 years, and we had a great time in this very highlight skull-based surgery, discussed many topics, many occasions. Imad Kanan gave me the topic of complex surgery of posterior fossa, tumors, many tumors, and especially here, the paradigmatic petroclival meningioma. I think we all know, and we already could see this during the previous lectures, and probably will see it also over the next lectures. It's a majority of these complex tumors, as you see here, skull-based tumor, treated nowadays with a high degree of radicality and a high degree of safety for the patient. Petroclival meningiomas, which have been mentioned several times during the previous lectures, still represent a very special entity. And for me, over many years, and sometimes even nowadays, it is something like not only the paradigmatic skull-based tumor, as I think the very complex and very difficult skull-based tumor, but also in many ways, especially in the way of decision-making, talking to the patients. It's something like a neurosurgical enigma. As Imad has asked us to direct our lectures also to the education of the younger neurosurgeons, I think it's quite appropriate to just give a short glance at the history of these tumors. And most of you know this, of course, but it was first described in 1953 by Castellano and Ruggiero in their book on meningiomas of the posterior fossa. And at that time, and with their technical knowledge, their anatomical knowledge, and of course, without very refined neuroradiology, they said that in their opinion at that time, clivus meningiomas, as they named them, were inoperable. The first big breakthrough came, of course, like many other things, also by Professor Ghazi Yajagil. He published in 1980 in Advances in Technical Standards his book on meningiomas of the base of posterior cranial fossa. And here he described the clival meningioma, as he named them. And he described the growth direction of these tumors and how these tumors could be addressed and could be exposed surgically, altogether with the excellent drawings of his ingenious drawer, Peter Rode. And he stated at the time in the same book and in the same publication that clivus meningiomas in particular have until recent years been uniformly lethal. At that time, 1980, in the hand of a very experienced surgeon. The outlook of such patients must be bettered by achieving earlier and more accurate diagnosis, by improving surgical technique, and a better understanding of the pathological anatomy. The first larger series of clival or petroclival meningiomas was by Albino Bricole, published in Neurosurgery in 1993, 13 years after the publication of Ghazi Yajagil, his results. And he stated that in nearly all cases, the patient came out in worse clinical and neurological conditions after surgery than before, and therefore needs constant meticulous assistance. This is already a very strong word of warning in regard to the surgical attack of these very complicated surgical cases. Probably the most important things developed in the next 20 to 30 years and started by the development of surgical principles, new development of surgical principles in petroclival meningiomas, all based on a good and very thorough understanding of the complex skull-based anatomy. This was, of course, Samuel Mefti, Takeshi Kawase, we heard it too in this wonderful lecture, Majid Zami, Ladik Msheka, and our good friend Ohata, and of course, Takanori Fukushima and Bill Caldwell. They published the first very large series in 1996 of 109 cases. And this probably paved the way for more aggressive attacks on petroclival meningiomas. If we go to PubMed to see how the development in the neurosurgical literature came about, it is very interesting. In the first years, up to the year 2000, there were less than 80 publications, as you can see here. It started a little bit more or less in the years between 1991 and 2000, and then the explosion of publications, scientific publications of the treatment, of the diagnosis, of the anatomy of petroclival meningiomas, especially also in regard to approaches, came in the year of 2001 and 2021. In the last 20 years, 370 publications, which is, I think, absolutely amazing, and it demonstrates the interest that we all had in this kind of tumors. This is my personal series over the last almost 30 years. And I was working at 4 academic institutions, and you can see altogether quite a large number of petroclival meningiomas. But even over this time, there were not more than 6 or 7 petroclival meningiomas a year. Only if you collect them as a series and you have a special interest, you can get enough experience to deal with this very difficult lesions. Quite some patients were lost to follow up. And you can see that there were different treatment modalities used: microsurgery alone, combination of microsurgery and adjuvant radiosurgery, alternative radiosurgery, and observation. I will not go into details about our results. I've presented this on many, many occasions and discussed with some of the experts which are here today and also with others. But it clearly shows that probably surgery alone is not the only way to deal with these patients. And I think one of the topics of my talk is also to open the door for younger neurosurgeons to think about different modalities in a very patient and also very surgeon-oriented way. So I would like to make it quite practical. So I will explain our conceptual thinking in petroclival meningiomas in 7 illustrative cases, which hopefully demonstrate our experiences in some ways and our conceptual thinking in these patients. Now, of course, the first question is always how to approach these tumors. We have seen this in the wonderful lectures by Professor Ohata, Professor Kawase, Professor Fukushima, and I've learned a lot from all of them, especially from Takanori, which is a very good and very long-time friend of mine, and his wonderful surgery had really taught me a lot. I think, of course, the location and the growth direction of a petroclival meningioma clearly dictates the surgical approach. This can be sometimes very confusing. A lot of approaches have been developed over the last years, many of them, and it's quite difficult to understand which approach one should use for a very special tumor, or a very special petroclival meningioma. If we go a little bit more into detail, it all goes down to more or less 3 operations. This is the orbitozygomatic approach to those who are primarily in the temporal and in the anterior fossa. I will show case later on. The combined transpetrosal, obviously also one of the workhorse. We have seen wonderful experiences of this and wonderful examples by the previous speakers. And of course, what I probably say, the suboccipital retromastoidal approach, which is in many ways extremely straightforward and very versatile for specific groups of petroclival meningiomas or for specific surgical concepts. This is our surgical approaches in our patients which have treated by surgery. A relative small amount of patients were treated with a petrosal approach. And of course, the retromastoid was also my workhorse, and the other approaches were relative. Where I would like to draw your attention also to the possibility of stage operations in number of patients when it is really justified to think about this. Our colleagues from Asia here, from India, have said that the retrosigmoid approach is the workhorse for petroclival meningioma. I think so too, because this is extremely convincing, very quick and very easy to do, and you have almost no approach-related complications, which can be very different in complex approaches. And there was a saying, the more the word pre is in the surgical approach, the higher the number of complications. So we also have to think about this, because we should always use approaches as very well known as very quick or relatively quick and without major complications. This, of course, first case, this is the classic petroclival meningioma, as you can see here, quite large, 52-year-old male patient, progressive gait disturbance over 12 months, discrete lower cranial nerve affection. If you look at the MRI on the right side, you see there is only a very mild, if at all, brainstem edema, and the surgical approach here was in the lateral position. As you can see, a relatively small opening, and then the removal of the tumor. The difficulty in these tumors lie, of course, in the fact that the tumor is anterior to the cranial nerves, so you have all the time work between these cranial nerves, and during that period, there's always a danger that you put these cranial, very vulnerable nerves to some sort of injury, which of course should be avoided at all costs. This is the post-operative picture. You can see that the tumor could be completely removed, even down to the lower cranial nerves. And we had post-operative a slight facial nerve palsy, a little bit of hoarseness, but otherwise no severe neurological deficits. The patient later on was full-time employed. That's, of course, a case that we all love, where we can really do very good neurosurgical, straightforward work. That's another case. This is also a large petroclival meningioma. Vast majority is in the posterior fossa. The small part is in the Meckel's cave and in the temporal fossa. But you can see that there is a massive edema in the brainstem. And you see also that there is a massive vascularization, as you can see here, by the Casanova Berescani, by the very vascularized vessel there that really makes the surgery right away very difficult also to close it before the endovascular means. And this patient was already quite sick. She had a progressive gait disturbance, hoarseness, problems in swallowing, and so on. And here you can see we operated in the semi-sitting position, which I like for many of these tumors using the combined petrosal approach. And when you look at the post-operative picture, you see that it was possible to remove the tumor completely, can do surgically a very nice job by complete removal. But as you can see in the lower pictures, the edema increased a lot after the surgery, and there was some injury in the corticospinal tract. Probably we violated one of the very small perforated. At 1 year post-operative, the picture looks much better, but the patient has an extremely stormy post-operative course, which we also must talk about. We only can talk about our successes. Not all of the patients have a good follow-up and have a good post-operative course. Not frequently, especially in clival meningiomas, we must be honest to us, and really be quite clear that sometimes the course can be very, very stormy for the patient. The patient needed 9 months of continuous rehabilitation with then significant improvement. In the long-term run, she had a slight hemiparesis, she's able to walk, and she's part-time employed as a software specialist. So why is one tumor relatively easy? Why is the other one so extremely complicated? And of course, everything in the neurosurgical world can be found in the word Ghazi-Yajagi. In volume 4B of his books on microneurosurgery of CNS tumors, he stated that these tumors, and he directed this absolutely to petroclival meningiomas or clival meningiomas, as he named them. These tumors can be accessed, but the biological problem of dissecting the interface between adhesive tumor and vital structures remains paramount. If more radical dissection is undertaken, the consequence is a higher risk of deficits for the patient, in particular, oculomotor function and hemiparesis. And that's exactly what happened in the patient, because there was almost no interface between the brainstem and between the tumor. Two more examples to clarify this for the younger colleagues. This is a relatively young female patient, slight gait disturbance over 6 months, with great lower cranial nerve affection, quite a large petroclival meningiomas, which has partly incorporated the basilar artery. There is almost no severe edema in the brainstem, which gives me a good idea that you can probably remove the tumor completely without any real difficulties and without doing any harm to the patient. Here we are in the middle of surgery or in the last third of surgery. The large part of the tumor is removed. We are now approaching the brainstem, as you can see here. And if we put some tension along the tumor, you can see that we see and explore very nice fibers, arachnoid fibers. And if we see these fibers, it is relatively clear that we completely dissect the tumor from the brainstem. There is an intact tumor-pia brainstem interface. Here you can see the basilar artery. You see the very small perforators coming from the basilar artery. And if you see this also, you can be sure that you will be able to remove these tumors completely by delicate dissection of the perforators from the tumor by preserving the pia, and the pia, especially the pia along the brainstem. That's what we were able to do here. And you see a very nice postoperative result, very small, minor piece left in the posterior part of Meckel's cave, but the patient made a very nice course. And on the long-term run, there was no growth of this very tiny remnant. So this is another case, not very small petroclival meningioma, 60-year-old male patient, again, progressive gait disturbance, slight facial nerve palsy. But if you look at the MRI, you see there is a distinct edema of the brainstem, not very much, but the edema is quite clear. If we look at the intraoperative picture, we are almost exactly at the same area where we've been with the previous patient, but the view is completely different. There is no dissection area between the brainstem and the tumor, not at all. Everything looks like a pot of glue has spilled over the tumor of the brainstem, and even trying to dissect the interface is simply not possible. And you can see that every time I'm putting some sort of stress on the tumor, the brainstem moves with this. This makes it quite clear that the tumor cannot and should not be removed completely. This would bring significant harm to the brainstem and increase the preoperative edema, and will result in a complicated and difficult course. Here we are at the end of surgery. We left some part along the brainstem. Here you see again the basilar artery, and you see the oculomotor nerve. This is the image post-operative. You see that we have removed the tumor almost completely, but we left a small remnant along the brainstem, of course, which needs to be observed. But the increase in the edema was not massive, and the patient had, on the long-term run and the midterm run, a continuous improvement of the relatively small preoperative symptoms and deficits. So that's the way to go. And once again, we go back to Yazagil. It is the biological problem of dissecting the interface between adhesive tumor and vital structures remains paramount. How to advise the patient, how to advise the relatives of the patient. Do we have any hint how these difficulties will be? It is, of course, the MRI that shows us some ideas how difficult the surgery will be. And we have good data now from 2 more publications, but these are the most imminent publications on the MRI imaging in petroclival meningiomas. One is from the group of Makoto Nakamura, a teacher of Majid Zami, who was at the time working with Joachim Grause in Hanover. The other paper, as you can see here, from our colleagues from Italy, and both state that limited resection of tumor may be aspired to avoid significant postoperative morbidity. And the other very readable work by our Italian colleagues says, as a consequence of a tenaciously adherent portion of the tumor, radiosurgery is the best option to treat the residual lesion. I cannot stress this enough, not to overdo the surgical aggressivity, always to think of the patient and to think also patient-oriented. Of course, there are tumors which are large and complex, like this clivus meningioma, which extends down to the foramen magna, which looks very, very adherent. And it must be very adherent because we see the really massive vascularization of this tumor. Is it possible to remove such a tumor despite the possible adherence and despite the MRI picture and the vascularity? This is the intraoperative video. We are on the left side, as you can see. You see already the ladder dissecting. We see the quite large pica, as you can see here. And the problem with those tumors going relatively down is that you have some of the cranial, lower cranial nerves, which you have dissected from the tumor, which very often can result in the passagear lower cranial nerve deficit. The thing is, there is no way to get out of this bleeding because you cannot make a preoperative vascular occlusion of these vessels. All of these vessels are coming from the petrosal dura. The only way is to get to the petrosal dura and to occlude the vessel directly there at the origin. But before you can do this, you have to remove the tumors to reach the petrosal dura. That's what I'm doing here. So you cut out pieces, you accept the vascularity, you accept the bleeding, but you remove them, as some Mefti has said, piece by piece, layer by layer, cell by cell. And now I have reached the petrosal surface, the petrosal dura, and now we can relatively fast occlude the vascularity and then go again to the vessel and to the brainstem. Here we see the left-sided vertebral artery, and we can look over to the other side, see the right-sided vertebral artery, and we see once again that we have an interface, that we have a very good interface that we can dissect microsurgically. That is something that we cannot see before surgery, but it gives us a good chance to remove the tumor completely using meticulous microsurgical techniques. And by this, piece by piece, and then layer by layer, cell by cell, Samuel Mefti, we can remove the tumor completely. Here's the final art, and you see the vascularity is almost completely gone. We just took our time and occluded the petrosal dura, and by this occluding the vascularity. Here's the complete removal of the tumor. We're looking over to the contralateral side, and we can see the abducens nerve there, and at the end of surgery. Now this is before surgery, this after surgery with complete removal. Post-operative, there was a relatively mild to moderate lower cranial nerve deficit, but complete recovery after 6 months and no other long-term neurologic deficits. This is just to stress that you have not only rely on MRIs or angiography, but you have bring down your decision-making into the operative process and then decide if you would go on with removing the tumor completely, if you see the chance. But if you see that the interface is completely difficult, then you better stop and leave a small remnant and think in a patient-oriented way. Now, of course, we must talk about, if we talk about petroclival meningiomas, we must talk about radiosurgery, of course, not in detail, but we have good data now that radiosurgery in selected patients, which has to be, of course, discussed with the microsurgeon, is an excellent way to treat these tumors. This is the result of the very large multicenter study of our radiosurgical colleagues from the USA. And the results are very impressive, I think. At the last clinical follow-up, over 90% of the patients demonstrated no change or improvement in their neurological condition. That's nothing that we as surgeons can beat if we report our results honestly. Of course, the tumors treated by radiosurgery are much different from those who have treated by microsurgery. They are much smaller, although they are more adherent, but they are much more targeted to radiosurgery than to microsurgery. These are our own results from the Frankfurt Neuroscience Center, our Center for Radiosurgery. We see that our overall local control rate based on the lowest MRI was even higher, 90.6.1%. But even on the long-term run, we see that at 9 years, we have a local control of over 80%. So I think in many patients who are not able to undergo microsurgery, who are reluctant to undergo microsurgery, or whatever reason should be treated by microsurgery, radiosurgery is definitely a way to go. And this should also mean that we should incorporate radiosurgery in our counseling of the patient, in our surgical concept, how to treat a patient. This is a way how we do this, for example. This is a 65-year female patient with progressive gait disturbance, progressive light-sided hemiparesis, progressive oculomotor paresis. For the first time, she was bound, and she came with this tumor. And you see the massive compressing of the brainstem, as you can see here. You see the massive edema in the brainstem, and but you can see it, and you see that the basilar artery is completely encased by this tumor. So chances to remove the tumor completely in the age of the patient, of the female patient, are very low, at least to my experience and to my understanding how to treat these patients. So the concept was to remove the tumor as radical as possible without doing any harm to the patient, leaving maybe a small remnant has to be judged intraoperatively. Here's one of the drawings of the publication, the very early publication of Ghazi Yashagil, who had also approached one of his petroclival meningiomas using an orbitozygomatic approach, the same way we have approached it, as you can see. We see the post-operative result. You see, first of all, that the edema after surgery has even increased. Of course, this can be expected, so it took some time for the patient to recover, but you could see here that we could remove almost the tumor completely. We had to left very small area along the basilar artery perforators, which we didn't plan intraoperatively or had enough power to remove it. And I think it was a very, very good decision. Post-operative, we made a classical radiosurgery with a very small amount of radiation to this patient, and altogether the patient recovered very nicely and is still possible to live a normal and functional life, even with the age now at, I think, 67. Just a few words about endoscopic surgery, which has not mentioned by the previous speakers. It's not exactly the talk of our topics. I went once again to PubMed and looked at the publications. They are very rare, 26 publications up to 2021. And probably the largest was a publication by our colleagues from Japan when they looked at the current status of endoscopic surgery for skull-base tumors, meningiomas. Only a very small, almost going close to zero number of patients could be removed. Most of them were the endoscopic procedure was used to decompress the brainstem. It's almost exactly the same in the last publication of 21 by a very experienced group, Snyderman and Gardner, in endoscopic skull-base surgery, but even with them, radical surgery was in some ways not the standard result of surgery, but anything, it should be, of course, performed in the future and tried how much it can work in skull-base surgery. Probably a better way, Markus Tatajiva from Tübingen has published, is to use an endoscope-assisted petrosectomy in petroclival meningiomas, or use it also in several ways during petroclival tumors, which has published by our colleagues from China in the Turkish Neurosurgical Journal. Let's come back to a staged approach, which has officially published for the first time in 2011 by Majid Zami and his group. And it has opened up the horizon for probably quite promising way of dealing with petroclival meningiomas in a quite patient and surgeon-oriented way. I had the honor to comment on this paper, which was very readable and, as I said, opened the way to another look at petroclival meningiomas. This is one of the publications of Majid Zami here from the publication. You see that they have removed the posterior part of the tumor, compressing the brainstem, and left in place the other parts for additional treatment. This is one of my patients, altogether now 12 patients with staged resection. This was a 60-year-old female pregnant patient with progressive gait disturbance and progressive diplopia. And she told me to wait until birth of her child child and then undergo surgeries. And she said to me, you can do whatever you want, but I don't have any complications from the surgery, which of course makes surgery for the skull base surgeon not very easier. So I decided to remove, looking at the intraoperative way, how to do it, the posterior part, compressing the brainstem and probably leaving the anterior part in the temporal fossa untouched. Once again, here I use the semi-sitting position. As you can see, this is the intraoperative video. I will not go into detail, just once again to have a look at these sometimes truly very difficult and very vascularized monsters. Now, we were able to remove the tumor in the posterior part completely, as you can see, and even down to the meatus acousticus. The patient had a very nice postoperative course and a very, very mild facial palsy, but that's all she had. We followed her up, and it is very important in this kind of approach that you devascularize the tumor completely along the lower part of the tentorium. This, on the long-term run, as I have learned, results in a decrease of the temporal tumor size. And this is the patient after surgery, I think about 1.5 years after surgery. So what have we learned? And hopefully what our young colleagues should learn in the future. Of course, they have to make it better as we do it. But I think now we have a clear understanding and knowledge of skull base new anatomy, especially thanks to many of the previous speakers. We have a routine availability of highly sophisticated preoperative imaging. We have an increased and very good understanding of the tumor-brainstem interface, especially during the recent publications on MRI. Routine application of intraoperative monitoring. We have a routine, but as I would put it, critical use of complex skull-based approaches, increasing reuse of standard approaches, the workhorse idea, at least in my understanding. But by this, we have the avoidance of approach-related complications. We have a quite good and increased knowledge of the natural history of un- and partially operated petroclival meningiomas, which is in many patients much better on our long-term run as we have initially thought over many years. I truly believe, and that's the way how I advise my patients, limited, not over-aggressive locality of tumor removal with intraoperative judgment of an experienced skull base surgeon is probably the best way to deal with these tumors. And finally, incorporation of radiosurgery and stage resection into the treatment concept and the way how we should counsel our patients and his relatives is extremely important. This is not only my idea. When you look at the publications on petroclival meningiomas over the last years, you see that many of our colleagues follow the same way. They say that in 1996, Takafuku and William Coldwell, we are in agreement with others that in avoidance of surgically induced deficit remains a primary consideration. It goes over there where the face of Vladimir Benish is to be seen, that having a limited radicality. I personally have said that excellent results can be achieved by tumor control and preservation of life. And Anil Nanda, also a colleague of us, a very good skull base surgeon with which I have discussed many times the treatment of petroclival meningiomas, he said, the author's primary goal was to achieve maximal resection while maintaining or improving neurological function. Our colleagues from India, Suresh Nahia, I know him very well. He's an excellent surgeon, and he has already said the same in 1980, trying to obtain tumor removal, but at a high risk of additional further neurodysfunction is not acceptable in the present area. In 2019, our colleagues from Korea had planned incomplete resection and subsequent radiosurgery is a feasible option for the management of patients with large petroclival meningiomas. And again, in 2019, Hugues Roche, our colleague from Italy, and Bernard, they stated, it's only 2 years ago, not maybe only 1 year ago, optimal subtotal resection of petroclival meningiomas with postoperative radiotherapy or radiosurgery results in long-term tumor control rate equivalent to radical surgery. So if we see these plethora of tumors, it still remains difficult how to treat them and to talk to the patients, to the relatives, and to really find a good concept in any individual patients. At the end, I think we can say that current management of petroclival meningiomas, exemplary, at least to my understanding, demonstrates the shifting paradigms in the treatment of complex fibrous meningiomas over the last 3 decades. I think the last publications clearly demonstrate this. Eminent role, there is no doubt about this. Treatment of petroclival meningiomas must be seen within a multimodal treatment context with which excellent results can be achieved. At the end, I would draw your attention to this publication that has been appeared in March 2021 in the Acta Neurochirurgia, also just 1.5 months ago. It comes from the group of Sebastian Fröhlich in Paris, and they have an immense amount of work and put together all the data on petroclival meningiomas and together with the ENS skull dissection. I personally had the pleasure and the honor to be invited to work as external expert zusammen mit Vladimir Benisch, Taka Fukushima, Sam Mefti, Keiichi Ohata, Markus Tatajiba, nur only mention a few. I think this will be a reference publication where everything can be found and which will be valid for many, many more years to come. Thank you very much for your attention.
Professor Seifert, thank you very much. That's an excellent talk, a fantastic systematic review and very honest review of the problems we face in this difficult pathology. I think we have time for one comment or question. Does anybody want?
Yeah, I make a comment.
I would like to. Yeah.
Professor Bennett and then Dr. Zhao. Yes.
Volker, this is Keki Turel. Thank you very much for this very nice update. My question is, if you see a young patient with a smallish tumor and no neurological deficit, what would you do? Would you prefer to observe or would you prefer to operate and excise it completely? Young patient, practically no deficit or incidentally?
Yes. That's one of the questions we love every day in our outpatient department, if you see such a patient. If it's a young patient or if it's an older patient whatsoever, and he has absolutely no signs, just without any problems, without deficits, I would just stop and observe him. Because the long-term run of these tumors is completely unpredictable. I've just seen a patient from the Netherlands, which had a very relatively small tumor, which had been treated by radiosurgery 25 years ago. And the tumor had become a little bit smaller, no signs of growth. So it's quite unpredictable. Very often I see patients, much more often than younger patients, I see older patients, 65 years, 70 years, sometimes 75, with large tumors without any symptoms. I have patients who are coming from the golf course. They come with the proposal by a neurosurgeon to have this tumor removed. And I think this is something we really must think about. If we would advise our relative, our wives, our friends, whatever, if they should undergo a surgical removal in a tumor without any problems. Many of these patients I can observe over several years, and even with 75. I have patients who have become 83, 84, 85, and the tumor remains almost the same size. If the patient has no symptoms, I think it is absolutely justified to wait. If the patient has symptoms, of course, then we have to go ahead. No doubt about this.
Thank you very much. Vladimir.
Yeah. Volker, I always enjoy the lecture on petroclival by you because it's so reasonable and so logical that there can hardly be said anything. I just would have one technical remark. In all the tumors which are above the level of the meatus, I use the supracerebral infratemporal approach. And the advantage is that very early on, I cut the tentorium along the medial border of the tumor. I have very good control of the superior cerebral artery, very early control of the third nerve. It's very easy to resect the subtemporal part of the tumor, but most importantly, as soon as you push the tumor a little downwards, you very early on in surgery see the interface between the brainstem and the tumor, and you just go downwards. Very easy, very straightforward approach, which gives you more space than a regular retrosigmoid.
Yeah, you're right. There's only one point, and I completely agree with you. We also have these tumors, but I completely agree. But these tumors who are located above the level of the meatus, they are very rare. And we see them sometimes when they are very small, then they are very difficult because there is no space to deal there. It's difficult. If they are large, they are very, I have only a very small number of patients in which the anterior part, rostrally, of the meatus is very large. If this is the case, then I would completely agree with you and would use the same approach. But many patients, the tumor goes down at least to part of the lower cranial nerves, and then you have to, of course, to use the classical approaches, at least one of them.
Sure, you can even combine it.
Yeah, of course, you can. Yes, you can do this. But it's a good addition of the standard approach. I completely agree. Yes.
Thank you.
Thank you very much.
I have one question. I want to play the devil advocate on this subject. Now, you said if you have a young person with asymptomatic, but you have a small retroclival or meningioma accessible, and you are sure you can achieve a good resection. I think maturity and age they push us to a more conservative line of management. 10 years ago, 15 years ago, perhaps you don't say this statement, isn't it? This is over the practice and the experience. Now, there are many tumors, they are unpredictable, yet we tackle them when they are in young people because you give a time span for these to become a difficult surgery. I mean, if you can go, if a tumor is above the meatus and you have a good access for complete resection with a very good outcome, why we should defer it? And with the potential, it might grow up, adhere, and it make a less complicated procedure and more difficult. I know this is unpredictable unless you tell me you are going to check 1 or 2 years and see the trend, how is they are growing. If there is a sign of growth, then you will go after. So what is your take on this?
Yeah, I think the answer is relatively straightforward. Of course, if the patient, for whatever reason, requests the surgery, of course, we can do this. On the other way, the main reason is, even in these cases, we don't have always patients who come out of this kind of surgery in a very good way. Even then, you can have problems. And if this is a 35-year-old female or a male patient, fully employed, very active, and you must have a good reason to send him to surgery, because nowadays we live in the time of MRI. You can make an MRI every year or every several months, whatever you do, and you see if the tumor starts growing, the thing is changing completely. But if the tumor stays completely stable, why would you expose the patient for a possible, not infrequently, even in some ways, dangerous surgery? It's very difficult. Not my daughter. My daughter is 34 years old. She is a doctor. If she would have such a patient, I would say, just wait. We can wait. We would see 2 millimeters, 3 millimeters. We see on the MRI. If this is the case, then she will have to undergo surgery, radiosurgery. But without any symptoms, at the first, we see many patients coming from outside with the first MRI showing a petroclival meningioma. It's the same with a patient with a 4 millimeter or 5 millimeter aneurysm. The literature is quite clear for this. There is no scientific reason for her to undergo surgery. At least this is my opinion. I know some very experienced scalpel surgeons who have the same opinion, but it's a matter of discussion, of course, absolutely.
It was not the consensus. I imagine it's not the consensus on that paper published by all these names.
This skull base by the European skull base paper.
When I saw Sam Mufti and others on this paper, are they agreeable to this approach?
No, please read the paper. You get it there. It's about everything. It's about the radical surgery. It's about the waiting period. It's about the stage surgery. Everything is put there. So you found everything there. This is not a consensus approach. The consensus is that there are different options, different ways how to treat these patients. And that's why even someone like Sam El-Mefti, who I admire very much and I really adore him, but even someone like Sam El-Mefti, who does surgery in the vast majority of his patients, agreed to this publication. It's a very diverse publication, very readable. All aspects are covered here.
We have forgotten one aspect, Volker. We have forgotten hormonal treatment in women between 50-60. Quite free. We all know the relation between the pregnancy and meningioma, that they can compensate. And if you get a patient, female patient who is 50-55, treated by the gynecologist by hormones in their menopausal time, she's oligosymptomatic. You take away the hormonal treatment and suddenly the lady is without any problems and you may observe the tumor.
Absolutely. I mean, you are some of the advisors of this AINS paper. And of course, this is also covered there. But I would not cover this aspect in my surgically oriented lecture.
Right.
Thank you very much. Thank you again, Professor, for an excellent presentation and stimulating a fantastic discussion. Thank you.